Hi guys, welcome to today's episode of Guideline Review of the Week. Today I shall be discussing a case scenario which we encounter very often in our OPDs. We get a lot of these patients. We have a lot of women who come to us with scans which suggest that they have some cyst or some mass in their adnexa. They are often postmenopausal. Of course, we have a lot of women who are premenopausal and who have similar complaints or who have similar presentation. And I shall be discussing that in a later grow video. But currently, today, my focus of discussion is primarily going to be all those postmenopausal women who have come to me and they have a mass. So today's guideline is based on yet again the management of ovarian cysts in postmenopausal women by RCOG. It's a green top guideline. This guideline was last updated in 2016. It's been 8 years since then. So there are a few aspects that I would like to change, or while I'm reading this through, I would want to make a few changes. I would want to mention a few changes that have occurred in the subsequent 8 years. But RCOG has not officially updated these guidelines. I don't know when the next update is going to be on this topic. The changes are insignificant. They are just minor ones, and I will take you through each and every one of them. So welcome and let's proceed. So first of all, I would like to discuss as to how do these women often come to us. So these women, the women who have postmenopausal cysts, I would just call them PMC. They can either come to me in the form of they have like come to me for some other complaint. They have come to me with something like some pain in abdomen, and accidentally or not accidentally, while examining the patient. So while examining the patient, I end up knowing that she has some mass. Or a female might have done an ultrasound for some other indication, or some imaging for some other indication, like she had abdominal pain and she had chronic constipation. So a surgeon asked her to get an abdominal and pelvic ultrasound done, and उसमें पता चला कि उसको है. So ultrasound findings, ultrasound for some other pathology, and the rest are the ones who have done that USG for some certain purpose. They have had some strong familial history which necessitated them to undergo an evaluation, a routine screening procedure that they have been undergoing, and usme pata chala. So intentional imaging. So these are the three ways in which a patient will eventually be diagnosed with some postmenopausal cyst. So is it that significant? Yes, the incidence is quite significant. It is very common. Even they say that it is quite common in postmenopausal women. The exact prevalence is obviously unknown, but it is said that almost 5 to 17% of the women have it, which is approximately like 1 every 10 females have it, which makes the 1 in 10 to 1 in 5, which makes the incidence quite more common. So it definitely merits understanding how shall we be managing these women. Not all patients are candidates for operative interventions. There are few women, there are in fact most of the women who would not need any intervention. So I'll be talking about an algorithm as well later on. Also, the greater use of ultrasound with an increase in medico-legal practices and all, nowadays we require documentation of everything that we do. So a documentation also in the form of imaging, so that we are quite confirmed that we are not missing out on anything, especially with an increasing incidence of obesity, metabolic syndrome. Women tend to be obese and our examination findings are often confounded by that abdominal obesity. So we end up doing an imaging most easily accessible, and the most cheaper one out of all the possible imaging investigations is obviously ultrasound. So an increased use of ultrasound has ended up giving more diagnosis of these cysts. Of course, CT scan is also being done, but CT scan is not the primary. CT or MRI is not the primary modality that I'll opt for. CT and MRI could have been done for some other indication by some other department like general surgery, जिसमें गलती से या फिर accidentally पता चला कि इसको menopausal cyst भी था. So over here we shall be considering only the significant cysts, and by significant cyst I mean to say cysts that are more than 1 centimeter in size. The one that are smaller than 1 centimeter are clinically inconsequential and they do not really have any increased risk of malignancy. So I would not be considering any cyst, as a significant cyst if it is less than 1 centimeter in size. How do I manage them? There are various ways in which I can manage. If I believe that the mass has some risk of malignancy and I'm not someone who's trained in the treatment or in these surgical procedures that are being carried out for patients who have malignancy, there are two conditions in which I, as a gynecologist, would like to tell you all that if you are someone who, as a practicing gynecologist, have no experience in operating over gynecological malignancies first, and secondary endometriosis, do not touch them. You would end up giving the female a suboptimal outcome. She might require a repeat intervention, a repeat surgical intervention, and the comorbidities with the surgical intervention that is repeated are quite high. So if you're not experienced enough, if you're not trained enough, if you're not doing it too often, do not go ahead with someone who has endometriosis or someone who has gynecological malignancies. Take that proper training and then only go ahead with them. Give the patient an optimal outcome. So my first option will be referring the patient to a gynec onco if appropriate, and by if appropriate it means if there is any likelihood of malignancy that the patient might have, who might require staging laparotomy, which I probably may not be trained for. The other way of operating or like managing these patients is using conservative management. Conservative management is just waiting and watching the patient. I'll be calling her back after 6-7 months and asking her to repeat the USG. I would be seeing if the USG has similar findings, or has it regressed, has the cyst regressed, or has the cyst increased in size, has the feature of that cyst. If it was simple earlier, now it has become malignant, or now it has become complex. So ये monitoring करूंगा मैं, but for now it will be conservative. And the other way is use of laparoscopic or robotic methods if available, and avoiding laparotomy as much as possible. Nowadays, there is an increased emphasis on laparotomy and on laparoscopy, I'm sorry, and hence laparotomy is something that is not really offered much, especially in setups where there is expertise available for laparoscopy, for robotic surgery. They are the ones that are preferred even for malignancy. Of course, a full body examination is required, including body mass index. Why do I say body mass index? Body mass index, because nowadays, as I mentioned, obesity is increasing. With increasing obesity, there is an increased estrogen content in the body. This estrogen can lead to the possibility of endometrial cancer, type 1 endometrial cancer. So body mass index is an important factor in that. I also will do a per abdominal examination to detect ascites, pseudomyxoma. Often all these ovarian masses will end up having ascites. So I would want to examine her, and I would also want to examine if there is any palpable mass on vaginal examination. If it's a gross big mass, which is even easily appreciated on doing a mere examination, I would want to check her for that. So a detailed physical examination is a must. The next important point over here is family history. There is nothing more important than family history whenever you are thinking of the possibility of malignancy. In postmenopausal women, if there is any growth in the pelvis, think of malignancy. Do not rule out malignancy without you are confirmed of it. And family history can go a long way in deciding whether this patient is at a high risk of malignancy. So, what is what is a significant family history? In that, a first degree relative, and by first degree relative yani the patient's mother, the patient's father, sister, brother, daughter or son. So basically a first degree relative is any of these. If any of these, इसमें से अगर two या more individuals had any type of ovarian cancer who are obviously first degree, they are at a high risk of developing ovarian cancer themselves. If at least one of these individuals had ovarian cancer and any other one had a breast cancer and it was diagnosed under 50 years of age, they are at a high risk. A female or a patient who has a relative who had ovarian cancer and who had two with breast cancer under the age of 60. So one under the age of 50 or two under the age of 60 along with ovarian cancer. I'm not saying that it should be the same person who has both ovarian and breast cancer. It can be one relative, first degree relative, who had an ovarian cancer and the other one who had a breast cancer. Apart from that, if there are three or more family members who had colon cancer, Lynch syndrome basically, or two with colon cancer and one with stomach. So basically, anyone who has gastrointestinal or urinary tract or small bowel cancers in 2 generations, they have to be looked after for the possibility of Lynch syndrome. In my opinion, though, I wouldn't keep the threshold as high as two relatives or three relatives. I would even examine her, or I would even evaluate her if there was one relative who was a first or second degree relative who had these conditions, and I would go ahead and examine them. I wouldn't really wait upon for two or three members to have it before I start evaluating this female. And of course, if there was one individual with both the cancers, of course, in the family, you have to go ahead and do. So basically, family history is very important, and you have to elicit a very detailed family history. The patient may be very unaware of this, and they might just brush it off. They might never even tell you about it. You have to voluntarily ask them leading questions and elicit this history from them. Of course, a female is going to be at a high risk if she has these mutations, BRCA1, BRCA2, and mismatch repair genes mutation. If she has them, she is at higher risk of developing endometrial or ovarian cancer. Do not forget that. So, what are the tests that I should be performing in a female who has this post-menopausal ovarian cyst? Is there any screening test? Yes, I have a screening test. Though the screening test doesn't have great sensitivity and specificity, it's still good enough. So, CA125. So, carbohydrate antigen, yes. By the way, a lot of people call this cancer antigen. No, this is carbohydrate antigen 125. There are many such antigens, CA99, CA125, CA, बहुत सारे हैं ऐसे. But CA125 is very classical. It is used for primary evaluation. It is a marker for epithelial cell tumors. यहाँ पे दिया है epithelial cell tumors. So epithelial tumors कौन से होते हैं? It can either be a mucinous adenoma, cyst adenoma, or it can be a serous cyst adenoma. So when I talk of age groups, I'll just brush upon an age group वाला part. In younger women, जो young होते हैं, who are in the reproductive age, or women who are in the reproductive age, or women who are teenagers or pre-pubertal even. Teenagers or pre-pubertal. All these young women, they are at a higher risk of having germ cell tumors. ये जो germ cell tumors होते हैं, things like dysgerminoma, non-gestational choriocarcinoma, yolk sac tumor, जिसका दूसरा नाम है endodermal sinus tumor, ये सब जो है, that is very common. Teratoma, these are very common in these younger women who are below the age of 40, who are below the age of 35, more so around the age of 20. For them, I do 4 major ट्यूमर मार्कर टेस्ट. आई कॉल देम एबीसीडी. क्यों? बच्चे, ये यंग वुमेन में हो रहा है. एक यंग बच्ची क्या सीखती है स्कूल में? एबीसीडी सीखती है. सो दैट इज हाउ आई रिमेंबर इट. सो ए से आता है मेरा अल्फा फीटोप्रोटीन, मेरा बी से आता है बीटा एचसीजी फॉर नॉन जेस्टेशनल कोरियोकार्सिनोमा, एएफपी से मेरा आता है योक सैक ट्यूमर, बीटा एचसीजी इज अ मार्कर फॉर नॉन जेस्टेशनल कोरियोकार्सिनोमा और एनी जेस्टेशनल कोरियोकार्सिनोमा. सी से आता है मेरा CA125. I also put CA99 इसमें. Of course, this is a classical epithelial cell tumor. Epithelial cell tumors generally develops in women who are perimenopausal and postmenopausal, but I wouldn't want to miss out on the diagnosis. Hence, I'll be doing it in this age group as well. And D से आता है मेरा LDH. LDH is a marker of cell division, cell turnover, and in tumors, obviously, there is going to be a high rate of cell turnover. So that is very classical. That is seen in dysgerminoma. It is not a specific marker, but it's a very sensitive marker for increased cell turnover, and hence LDH is for dysgerminoma. These are the major markers. Of course, there is teratoma. इसमें कोई भी इसमें से मार्कर बढ़ा हुआ नहीं आने वाला है. सो डू नॉट थिंक कि ये अगर नेगेटिव है इन द यंगर एज ग्रुप, मतलब कोई भी मैलिग्नेंसी का ट्यूमर नहीं है. देयर स्टिल कैन बी undifferentiated teratoma that is present, which does not give rise to any of these markers. वैसे ही as I come to perimenopausal age and postmenopausal, the likelihood of all these germ cell tumors decreases and the likelihood of epithelial cell tumors increases. Epithelial cell tumors कौन से मेरे पास? मेरे पास mucinous है, जिसका मार्कर है CA99, and the other one is serous, जिसका मार्कर है CA125. Now, one more thing that you have to remember is ये CA125 जो था, which I just spoke of, this CA125 is also increased in conditions that are classical to reproductive age women. Things like menstrual cycles. During menstruation, CA125 levels are modestly increased. Women who have endometriosis, it can be increased in them. Women who have PID, pelvic inflammatory disease. Basically, it's an epithelial cell tumor marker. So, whichever epithelial cells inside are affected, epithelial cells are present in your peritoneum, they are present inside your fallopian tube, everywhere, सब जगह present है वो. So, whenever there is any mass or anything, any pathology that involves these organs, वो बढ़ा हुआ रहेगा. Which is why CA125 is very unspecific for women who are young, whereas in elderly women who are beyond the age of 50, the possibility of them getting PID, the possibility of them getting endometriosis is going to be lesser. The possibility, obviously, of them getting menstruation is lower, and hence CA125 in these postmenopausal women classically points towards epithelial cell tumors. Fine. So the same thing that I just mentioned over here, that CA125 levels show wide variation in postmenopausal women, but the variations are not going to be towards alternative diagnosis that were possible in the younger women. यहाँ पे they have mentioned that non-gynecological, non-malignant conditions rather, like fibroids, PID, acute events, torsion, hemorrhage, and endometriosis, and even menstrual cycles can increase CA 125. So now that I've thought of this, is there any other alternative tumor marker that can help me in diagnosis of these tumors? Something that is not going to be increased in all these conditions that were like endometriosis or fibroids. Yes, there are a few more markers that are coming ahead, and उसमें से सबसे important जो है वो मैंने यहाँ पे mark किया हुआ है, that is HE4. HE4 is human epididymis protein 4. बाकी सारे भी है बट इस पे मैंने थोड़ा ज्यादा फोकस किया है. द रीजन बीइंग इट इज इंक्रीज्ड क्लासिकली इन ओवेरियन कैंसर एंड लंग, पैनक्रियाज, ब्रेस्ट, ब्लैडर, यूरेट्रल एंड एंडोमेट्रियल कैंसर. इसका ये मीनिंग है दैट दिस marker is very classically increased only in tumors and not in other non-malignant conditions. It is not increased in endometriosis. यहाँ पे they have given it is not increased in endometriosis, and hence it doesn't have those falsely positive rates as CA125 did. So they are now saying that few data has suggested that HE4 is a much more sensitive and specific marker than CA125, and a lot of institutions in what I believe also they play places that are classically the classical centers who look after malignancies, like in Mumbai there is Tata Memorial Hospital. They have started doing these tests for women, and it has slowly, gradually started to replace CA125 in a few conditions. So it's a much better marker, and hence they say that if I'm using HE4 instead of CA125, it would help me recognize 7 more patients with cancer with 81 fewer false positive. मतलब जो falsely positive आ रहे थे because of falsely raised CA125 because of alternative conditions, that is going down, and I'm having a much more higher chance of diagnosing malignant conditions. Hence, HE4, human epididymis protein 4, is a much better marker than CA125, but it is not yet widely available. What apart from just tumor markers can I do? Obviously, tumor markers are one thing, they're serum tests. I also have imaging studies. So on imaging studies, the best study that I can do is a transvaginal ultrasound. So when I do a transvaginal ultrasound, I can either be having a simple cyst or a complex cyst. So when I talk of a simple cyst, it is going to be round. The shape is going to be perfectly round. So the shape is going to be perfectly round. Proper round रहेगा. The surface is going to be completely regular. The wall is going to be very thin wall. So basically a wall through which I can see the fluid. I can see a clear fluid inside it, and if I'm going to handle it too much, the cyst will easily break open. There is posterior acoustic enhancement. Now what is posterior acoustic enhancement? Now imagine that यहाँ पे मेरा ऐसा अल्ट्रासाउंड का प्रोब था जो मैं ऐसे लगा रहा था. Now this probe, when it is giving out the sound waves, because of the clear fluid inside this cyst, it will put a posterior acoustic enhancement. Basically, the clear fluid inside this cyst is going to enhance the sound waves, and it is going to give me a brighter, enhanced version यहाँ पे sound का. Hence, we call it posterior acoustic enhancement. Enhancement is increased, acoustic is sound. So behind, posterior to this cyst wall, these sound waves are going to be amplified. That is very classical of clear fluid that is present inside. If it would have been blood, pus, or malignant cells, they would have reflected back the sound, and they would have not caused enhancement. They would have in fact caused decrease in the acoustic capability of the sound waves that was being transmitted. Apart from that, it is clear fluid, so it will be anechoic. Anechoic is basically no echo. There is no signal that is being sent from inside the fluid, so it is going to be clear fluid, and there is going to be absence of any septations or nodules. So the surface is regular. There are no loculations inside. There are no septations inside. This is very classical of a simple cyst. Whereas in patients who have complex cysts, they will have an irregular surface. They will have solid nodules like this. They will have septations, irregular septations inside, and they will also have papillary projections as inside from the wall. So these are very classical of malignancy, or rather complex cyst, which can even be malignancy. To determine these features, whether now this cyst that I have seen, a complex cyst, is it benign or malignant, there was a IOTA classification that was derived. I'm just going a little down. This IOTA classification was derived to make B and M rules. B were rules that were being made for benign cysts, whereas M rules were the ones that were made for malignant cysts. So women with an ovarian mass with any of the M rules should be referred to a gynecological oncologist, oncologist. So basically, even if there is any one of the M feature that is turning out to be positive, just think that she is probably having malignancy and you should refer her. So what are the benign and malignant rules? So in benign rules, of course, we have again read that unilocular without any loculation cyst. There is presence of solid components, yes, but the largest component is less than 7 mm. So even if there is a solid component, remember that we are talking here about the rules for complexes. So there might be a solid component, but if it is less than 7 millimeters, then I can be assured that probably it is benign. There is presence of acoustic shadowing. There is smooth multilocular tumor with a larger diameter less than 10 centimeters. So it is basically smooth. The surface is smooth, it is not irregular, and the largest diameter, basically the size of the cyst, is less than 10 centimeters. And there is no blood flow on color Doppler. Obviously, if it is not malignant, then it is going to be without any significant blood supply. So if I'm going to be talking about the benign rules or B rules, what all do I learn from it? Unilocular, of course. Solid area less than 7 centimeters, 7 millimeters, overall size less than 10 centimeters, and no blood flow. Whereas if I'm going to be talking about malignant rules, the surface is going to be irregular. There is going to be the presence of ascites in the abdomen. There are going to be papillary structures. There are going to be papillary structures, यानी ऐसे papillary projections रहेंगे inside this ऐसे papillary projections रहेंगे. And if they are more than 4, then it is likely malignant. The largest size of that irregular tumor is more than 10 centimeters, and there is prominent blood flow on color Doppler. Blood flow is indicative that the tumor is now receiving a lot of blood supply. It has started its own blood supply. It has started producing factors to increase angiogenesis inside it. So it is receiving a lot of blood supply. So coming back over here. Yeah. So what is the rule of ultrasound and Doppler? We have already said that do we use it? Yes, we use it. We can use it for doing the B and M rules. CT scan, should I be using it as a primary modality? No, don't use it as a primary imaging tool. In fact, reserve it for a patient in which a malignant disease is suspected. It's a very resource intensive thing. You may not have it in all the centers, and even if you have it, the costs are going to be quite high for the patient. So do not, and also there is the risk of radiation. So do not directly introduce the patient to CT scan. Do a good ultrasound first, classify if it is M or B, and then proceed to do with a CT scan. So the best use of CT scan imaging is not to detect primarily, क्योंकि detection तो USG पे हो जाएगा, but instead to evaluate the abdomen for metastasis when a malignant cyst is suspected. So metastasis can be to the lymph nodes, they can be to various other organs. So ये है कि नहीं, if there is lymphadenopathy, if there are enlarged lymph nodes, ये सब देखने के लिए use a CT scan. So use it sparingly. Also, it can detect omental metastasis, peritoneal implants, and pelvic or para-aortic lymph node enlargement. Also, hepatic metastasis, obstructive uropathy, if the tumor is blocking the ureter, and if there was any other but not an ovarian site of cancer, it can detect it. So keep it as a specialized modality. Though with an increased possibility of medical legal cases and all, if you think there is malignancy, you may just go ahead with CT scan. What about MRI? MRI in general can improve the overall sensitivity and specificity of ovarian cyst characterization, but there are few limitations. First of all, you cannot use it in patients who have cardiac pacemakers, cochlear implants. These women who are elderly women, they might have these implants. Also, it takes a long time. There are a lot of noises that the magnets inside the machine make. Women can or patients can be scared of those voices. वहाँ पे बैठना है आधा घंटा 45 minutes, they can be a little scared of it. You might have to sedate them. So for these patients, you might want to rather do a CT scan. Apart from that, it is going to be very expensive for doing it. So just reserve it for patients who can afford and in places where it is available. What all type of MRI can you do for them? Do a functional MRI sequence such as DWI, that is diffusion weighted imaging, and ADC, that is apparent diffusion coefficient, उसका कितना है वो derive करो. इससे you get to know what is the possibility that this is a malignant mass or if it is not. Now, I have seen what the CA125 is. I have seen the ultrasound. Now I have to combine both of them rather than evaluating them individually. I have to combine them and I have to decide whether this patient can be malignant or not. उसके लिए हमने बनाया था RMI. RMI was risk of malignancy index. So RMI बहुत सारे टाइप के RMI 1, 2, 3, but RMI 1 is the one that is most often used. So what is RMI? So RMI1 is a score which combines a few aspects. So what are those few aspects? The first one is we combine or we multiply the CA125 level. After that, we check the menopausal status of that female and then we make an ultrasound score. Now, how do we do it? सबसे पहले CA125 जैसा है, you just add that or you multiply that score directly to it. Next, menopausal status. If the female is premenopausal, make the score as 1. If the female is postmenopausal, make the score as 3. Now, इसका क्या significance है? Remember that if the female is premenopausal, that CA125 can be raised because of various other conditions. So we give a lesser score as 1 for premenopausal. Whereas if she is postmenopausal, it is likely that she has some epithelial tumor which के वजह से वो CA125 बढ़ा हुआ है. So if the female is postmenopausal, multiply 3. And finally, you see the ultrasound. You saw all those characteristics. उसमें से few important. There are 5 major characteristics. One is multilocular cyst. The second is solid areas, metastasis, ascites, and bilateral regions. So you have to check those cysts. You have to see how what is the characteristic of the cyst. If there is any one इसमें से feature from this 1, 2, 3, 4, and 5, इसमें से अगर एक भी positive है, so you take the score as 1. If the score is 2 or more than that, then you add a score of 3. So now, assuming that I have a cyst, जिसको UHD पे they have shown that it is multilocular and it also has solid areas. So यहाँ पे the score that I'll be having is 3. I'll be multiplying it with, if the female is let's say 57-year-old, she is postmenopausal, then again 3, and a CA125 score, or CA125 is 150. So for this, the score is going to be 3 into 3, 9, 9 into 150, it is going to be more than 1000. In fact, it is going to be 1350. 1350 is the score for her. We had another patient, she is a 25-year-old female who has a CA125 level of 100. So, and she has a simple cyst. So if she has a simple cyst, then I'll be taking a score of 1. She's premenopausal, then again 1 and a CA125 score of 100. So she has a score of 100. So we have these 2 patients. How do I interpret this score? So the score says that for any female who has a score more than 200, you have to refer them to a gynecological oncologist, whereas a score below 200 can be evaluated by a normal gynecologist as well. So a score more than 200 is suggestive of malignancy. Samjhe? So we have studied these M rules. Apart from that, we have multiple other scorings. There is one score in which we have combined those 2 markers, that is CA125 and HE4. We call that ROMA. ROMA is risk of malignancy algorithm. We also take into consideration the menopausal status to calculate the score. There's a calculator, there's an internet calculator that is not as simple as RMI, which is why this is not yet adopted much. It has a cutoff value of 2.27. So if the score is more than 2.27, there is a higher risk of malignancy. There is another one, that is OVA1, जिसमें हम लोग 5 अलग-अलग proteins evaluate करते थे. One is CA125, then there is prealbumin, apolipoprotein A1, beta-2 microglobulin, and transferrin. Theoretical concern at your level, at a postgraduate level, all you need to remember that there are multiple scores. उसमें से RMI is the one that we use, in which we multiply 3 aspects. One is the menopausal status, the other one is the ultrasound features of the cyst, and the third one is the CA125 value. Finally, do all postmenopausal women require evaluation and surgical intervention? Absolutely not. Women who are asymptomatic, they do not have any pain or torsion complaints. The cysts are simple, unilocular, and they are less than 5 centimeters in size. They do not need to be evaluated, or they do not need to be operated upon. You just call them back after 4 to 6 months with yet another USG. Of course, they need to have normal CA125 levels. After 6 months, you repeat the scan. If they have similar findings, you ask them to come back after 1 year. If the cyst size remains the same, the findings remain the same after even 1 year, then you can tell them that you don't need to come back to me. Whereas if she is symptomatic, then you need to go ahead with a surgical evaluation. Also, if she has a malignant possible mass, then you go ahead with operative intervention. What is the operative intervention? The first bare minimum thing that you can do is aspiration. You can just aspirate. You can put in a needle and aspirate the fluid out. But is it recommended? Absolutely not. It is not recommended. The reason is that the evaluation, cytological evaluation, is not good enough for describing whether it is malignant or benign. You need the cyst wall, you need the entire cyst to be evaluated. The mere fluid cytology is not an adequate thing to be assessed for malignancy. Apart from that, this procedure is not therapeutic. almost 1 out of 4 women will have recurrence within a year of the procedure. So I will end up doing the procedure multiple times. So there is no relief, there is no permanent cure to it. And finally, the most important part is the aspiration can induce spillage and seeding of cancer cells into the peritoneal cavity. So when I'm removing this, there can be a few drops that will fill in the peritoneal cavity and there will be metastasis. And hence, I do not wish to do and I will never do aspiration. The only reason in which I would do aspiration is for women who are medically unfit for surgery or in whom the symptoms are too severe and they have advanced stage of malignancy in them. I will aspirate them so that they have relief from symptoms for a short period of time. Can they be managed with malignancy? Now, this is one change that I was speaking of. They are suitable. They of course say कि RMI जिसका less than 200, they can obviously be operated. Though I believe now they say that laparoscopy should not be done for women who have an RMI more than 200. But in my opinion and experience, you can do laparoscopy and robotic surgery for all patients who even have malignancy. All you need is surgical expertise. What do? You do complete bilateral salpingo-oophorectomy and not just cystectomy, because you might just end up removing the cyst and you can end up leaving a few seeds of ovarian malignancy over there. I do not want that, so I will remove both the ovaries. Obviously, if one ovary is affected, there is a chance that the other ovary might be affected as well. I do not want that, and hence I will remove both the ovaries and even possibly of course, the fallopian tubes and the ovaries, because fallopian tubes are one of the major starting points for ovarian malignancy. So fallopian tubes and both the ovaries, and if required, the uterus as well. Of course, the surgical specimen has to be removed without any intraperitoneal spillage. So an endobag has to be introduced inside. I will put in a plastic bag so that there is no spillage of the contents around. When should laparotomy be undertaken? A laparotomy, they say that it has to be undertaken if RMI is more than 200 and if CT and all findings are suggestive that it might require a staging procedure. So in my opinion, a same outcome can be acquired if you have expertise for laparoscopy and laparotomy. But what is the procedure that has to be done? The procedure that has to be done is staging laparotomy. So in that, you will be doing cytology, you will be taking the ascitic fluid, you will be taking multiple biopsies of multiple sites. You will be taking multiple biopsies. The biopsies will include the omentum, the peritoneum, the undersurface of diaphragm. You will be going in a clockwise direction. Total abdominal hysterectomy is a must, and bilateral salpingo-oophorectomy and omentectomy. Infracolic omentectomy is required. So basically, staging mein, I open the abdomen, I check inside. Whenever I open, the first thing that comes out is the ascitic fluid. I send the ascitic fluid for cytological examination. After that, I see the omentum. I take a biopsy of the omentum. Then I go in a clockwise direction. I take a biopsy of all the things that come in my way. And finally, when I'm done with it, I also check the aortic, para-aortic lymph nodes. I also check the pelvic lymph nodes. If they are not involved, then I leave them alone. If they are involved, I'll remove them as well. Finally, I will remove the omentum that lies below the transverse colon, and finally, total abdominal hysterectomy and bilateral salpingo-oophorectomy shall be done. So finally, making a chart out of this, how do I manage these patients? A patient comes to me, she has a post menopausal cyst, then I measure the CA125 and I also do a ultrasound for her. I calculate the risk of malignancy index. How do I calculate it? Menopausal score मेरा सबसे पहले लूंगा, multiplied by my ultrasound features, multiplied by the CA125 score. If the score is coming less than 200, the risk of malignancy is low. If it is coming more than 200, I will do a CT scan or an MRI and I will send her to a gynecological oncologist. Whereas if it is less than 200, then I will see if the size is less than 5 centimeter, if it is unilocular, if it doesn't seem to be malignant, then I will just wait and watch and I'll call her back after 6 months. Whereas if it has any of the features, like it is symptomatic, she's having pain, she's feeling a lump, if it has complex features, we have already discussed the complex feature like solid surface, loculations, irregular surface, and it is multilocular, and if it is bilateral on both the sides, then I have to consider a surgical intervention, and the bare minimum that I have to do is bilateral salpingo-oophorectomy and if required abdominal hysterectomy. Finally, after 6-7 months, if it has resolved, I don't do anything. If it has increased in features, then I will go back and do it the way I manage a complex cyst. Finally, if I have to operate on a tumor, if I'm a gynecological oncologist, we nowadays prefer laparoscopy, but if you don't have the laparoscopy services, then you go ahead with a staging laparotomy in which you take multiple biopsies, you send a sample of the ascites, and you do total abdominal hysterectomy with bilateral salpingo-oophorectomy. And that is it with today's session. I hope you all understood this lecture on managing postmenopausal cysts. We have also discussed a bit on postmenopausal malignancy and ovarian malignancy and how will you manage it. I will see you again next week in yet another episode of Grow. Until then, goodbye. Signing off, Dr. Aditya.